All right. Well, welcome everybody. Thank you so much for joining us on this Tuesday afternoon for today's Doctors In webinar on bone health. Going to turn it over momentarily to Dr. Elizabeth Spina, who is back with us for another Doctors In presentation. I'm happy to have you back with us, Dr. Spina. But just a couple of notes to share before we get started here today. So if any of you who are new to Doctors In, this is a partnership between the LGBT Elder Initiative at the William Wade Community Center and Jefferson Health, specifically the Jefferson Department of Family and Community Medicine and the Jefferson Center for Urban Health. So we've been doing these programs for the past couple of years, each month addressing a different health issue impacting LGBTQ older adults, always with Jefferson providers coming in to share their expertise each month, and so we're so grateful for them for continuing to do these programs with us even through this crazy past year, where there's obviously been a lot going on with the healthcare system. So today's topic is bone health. Liz is going to lead us through the presentation. All of you who are with us in Zoom should have access to the chat feature and also to the Q&A feature. So at any time, you're welcome to either put comments into the chat or to submit questions. And I'll be keeping an eye on both of those, and we'll be able to relay those to Dr. Spina with any of your questions. And so just to note that anything you put in the chat, your name does appear with that. The Q&A, there is an option to ask those anonymously. There's a little check you can click in the Q&A to ask your question anonymously. So if you are asking anything more personal, about your own health and you want to keep that anonymous, use the Q&A feature instead of the chat. And anyone with us on Facebook can ask their questions through the Facebook comments. I'll keep an eye on that as well and relay those during the presentation. So thank you again, everyone, for joining us, and I will turn it over to Dr. Elizabeth Spina.
Thank you, David. Hello again, everyone. It's nice to be back. So my name is Elizabeth Spina, but you guys can call me Liz. And so today I'll be talking to you about bone health. So let's dive into it. So what we'll go through today is we'll talk about what really happens to our bones as we age, what are the normal aging process. We'll talk about two major conditions, arthritis and osteoporosis, and I'll give you a definition for those. We'll talk about why our bone health matters so much. And then we'll identify some risk factors that can affect bone health, and really talk about how we can modify those risk factors. And then we'll also review ways that we can help those who develop arthritis or osteoporosis, and we'll go through all of this. So what is the normal process and what happens to our bones as we age? Well, bone is dynamic. It constantly breaks down and rebuilds itself up. And because of this really nice remodeling cycle, it gives it its resilience. And the balance is dependent on a ton of critical factors. There's a bunch of hormones and proteins and peptides that are all really important in maintaining that really good bone integrity. When we get an imbalance of some of those regulators, that's when we start to have more porous bones or weaker, brittler bones. As we age, we reach our peak bone density, so our strongest and firmest bone in the third decade of life. And then that slowly trails off throughout our years. And usually by age 60 to 70 is when we're more at risk of developing something like osteoporosis, which is a disorder which we'll define in a minute. Not only does age affect our bone health, but there are also a number of other critical factors that play into our bone health, and that is race and sex. And so women and people with estrogen will have a lower bone density mass on average, and people with testosterone will have a higher bone density mass on average. We also know that non-Hispanic Black people will have a higher bone density mass on average, And people of white or Asian American or Pacific Islander will have a lower bone density mass. Arthritis is another condition that we'll kind of define in a little bit. And that also increases as we age. And we expect that with 2040, we're going to have around 80 million people with arthritis. So what is osteoarthritis? It's a disease where you have the protective cartilage between joints that breaks down and causes some painful and swollen and hard to move joints. And really what happens is when you have a joint, you have a nice protective cushion between the two bones that's made up of fluid, that's made up of cartilage and tendons. And so what happens is that stability is lost and there is inflammation that happens because the bones begin to really rub up against each other. So what is osteoporosis? Osteoporosis is a bone disease that occurs when the body loses too much bone and makes too little or both. So it's essentially a porous bone. It becomes more and more spongy. We expect our bone to be a little bit spongy, but it's like an old sponge where you use it a lot and you start to see larger and larger holes, and that bone becomes more susceptible to breaks. So why does all of this matter besides, the obvious pain? But it's estimated that 32 million Americans have osteoarthritis, and almost a majority, about 43% of adults over the age of 65 have osteoarthritis, which is that bone-on-bone phenomena. And it's estimated that 12 million Americans have osteoporosis. 80% of those are women. And 1 in 5 adults over the age of 65 will have osteoporosis, and 1 of 4 adults over the age of 80 will have osteoporosis. So we know that these are really profound numbers that can affect large groups of people. And if we can impact that, and if we can affect that, then it's going to help people not have some of the sequelae that come with these diseases. So this is a picture of kind of our biggest fear, which is a fracture. So osteoporosis, like I said, you have that weak, more spongy bone. And what happens is that weak, spongy bone can't endure as much resilience for things like falls or kind of twists and turns. And people are more at risk of things like fractures. Fractures are unfortunately, and as we age, one of the biggest leading causes to pain, change in the way that we live, whether it's going to a rehab or going into a long-term care facility, being more dependent on our loved ones to help us. And so fractures are really profound. And if we can prevent those and continue people living the way that they like to live and that the way that they have been living, that's what we want to do at the end of the day. So, like I said, it matters because fractures can change the way we walk. It can lead to chronic pain. It can lead to disability, change in the structure of the way we live our life, and lead to kind of dependence on other people. And it can, because of all of those factors combined, it can really decrease our quality of life. So arthritis limits the activity of about 23.7 million American adults. And 1 in 2 women and 1 in 5 men will break their hip due to osteoporosis. There's a high risk of death and hospitalization related to fractures. And about a quarter of people who have a hip fracture will transition from their home to a long-term care facility. And then in 2018, it was estimated that a total annual expense of providing care was about $57 billion. So these are really, really big numbers. And if we can prevent these diseases, then we really are making a big difference. So a little bit more on arthritis. There are a number of different types of arthritis. So the most common, and what we see most commonly in older adults, is degenerative arthritis or osteoarthritis, as you may hear it. But there are other numbers of causes of arthritis. Inflammatory arthritis, another commonly heard one, is rheumatoid arthritis, which is a state where our body kind of creates inflammation. There's spondyloarthritis and, excuse me, and psoriatic arthritis, which are all kind of under the same categories as inflammatory arthritis. There's also metabolic arthritis. So you may have heard of disorders like gout and pseudo gout, which are deposition of different types of materials within that joint, which lead to inflammation. And then there are other types that are childhood arthritis, but we'll focus on osteoarthritis today since that's the most common type of arthritis and the most common arthritis in older adults. So some of the symptoms that someone may experience if they do have arthritis is pain at that joint, not just pain with movement, but also if you touch that joint space, if you touch around your knee or you touch around your shoulder and it's tender, you can have stiffness or loss of flexibility, grinding or popping. You may hear a click, or we kind of commonly will hear a grinding in the shoulder. You can have little growths of bone, which are called bone spurs, which can also lead to pain and discomfort. And then you can have swelling. So with inflammation, we draw in a lot of fluid, and you'll see some swelling and some changes that come just from the inflammation alone too. So how do we evaluate arthritis? A majority of the diagnosis can be made by clinical history, but practitioners can really define that you have arthritis with an X-ray. And so that's a quick image. If any of you have had an X-ray before, where they would take a picture of that joint. In this picture on the right, you see on the left-hand side of the picture is a normal joint. This is a knee joint, and in between the two bones, you see a nice black space. And that's our normal space between the femur and the tibia. And when you have a loss of that fluid and that cartilage and that cushion that helps that joint move freely, you'll have on the right side of the picture, which you see there's that loss of that joint space, and you see that bone on bone action. So you see that white touching the white. A physician may ask for you to go get additional imaging like an MRI, which can provide us with a better picture in terms of soft tissue and kind of the structure of the bone. You might be asked to get certain labs that look for inflammation. And if there's a really large suspicion that you have some of those causes like gout or pseudo gout or an infection within the joint, you may have to get some fluid taken from the joint space and sent for analysis. But these are generally reserved for more concerning cases, and we don't readily do these on everyone. The most common thing that we'll do is just a plain X-ray. So some risk factors that we know lead to arthritis are older age. So the more we use our joints, the more wear and tear they get. Women, because of a number of factors, including our muscles, our tendons, are at higher risk of arthritis. People with higher weight will have more pressure on those joints, and that will predispose you to arthritis. Repetitive joint injury. So say a football player or a basketball player that constantly hurts their knee or their hip will have more of a risk of arthritis. Repeated stress on that joint. Genetics, sometimes it just runs in the family that you have more of a risk of developing it. And then bone deformities, growing up with, say, a hip dysplasia. If you were born with a hip dysplasia where your hip kind of aligns abnormally, can lead to arthritis. And then smoking, which leads to kind of a chronic inflammatory state, can increase your risk of arthritis. So how do we prevent development of the arthritis? And sometimes there is just the natural age progression that will lead to it, but we should try to modify those factors that we can. That being maintaining a healthy weight, avoiding harsh repetitive motions, and really adapting an exercise routine that's friendly to your joints, which we'll talk about next. Remaining hydrated, because when we stay hydrated, that space in between the joint, that fluid will try to maintain bulk, the cartilage will try to maintain to be healthy, and so staying hydrated is important. And then staying active. We know that increased use and wear and tear will lead to arthritis, but we also know that avoiding activity can make arthritis worse. So it's all about a healthy balance. And then stopping smoking if you're a smoker. Smoking cessation is one of the best things that we can do for ourselves for a number of reasons, and including arthritis. So 2 out of 3 adults with arthritis will be overweight or obese, and only half of those will get weight loss advice. But people who do get weight loss advice are 4 times as likely to try to lose weight. So weight loss is a very important thing that we can do. So what are some, Dr. Spina, Liz, you're saying that I need to be active, but I shouldn't be too active. What should I do? You can use this mnemonic. It's called SMART. It's a joint-friendly exercise kind of tip to keep in the back of your mind. S starts for start low and go slow. That's kind of our key principle in geriatrics, is to not overdo anything in the start. Really test your body and see your limits. Start with low impact activities and modify your activities when your body says stop. When your body is really uncomfortable and it's causing a great deal of distress, change how you're doing that. So if you are a biker and that's the way that you've always gotten your activities in, but your hips are starting to hurt, change it up. Try something like swimming or Tai Chi or yoga. And then try joint-friendly activities, which we'll talk about in a second. And then recognize safe places and ways to be active. That kind of goes hand in hand with how to be joint-friendly. What are the activities that work with your body? And then talk to a healthcare professional if you do have any additional questions. So some joint-friendly exercises. Those are walking, cycling, swimming, yoga, and Tai Chi. Those activities, you'll get a good amount of strengthening also in your muscles with that, but also be easy on the joints. And that's really what can help us to strengthen that joint. So how would we treat it in the office? Oh, actually, this is a video I'll show you quickly, which goes through some stretches that you can do for arthritis.
First, we're going to be talking about the upper extremity exercises. We're going to talk about a mobilizing exercise and a stabilizing exercise. The first one is called the corner pec stretch. So the first thing you're going to do is you're going to find a corner in your home and you're going to place your hands on the walls. With your hands on the walls, you're going to stare at that corner and you're just going to slowly let your chest fall towards that corner. You should feel nice expansion in the chest as well as a stretch in the mid part of your back. You're going to hold this for 2 to 3 seconds and you're going to repeat this 10 times. The second upper extremity exercise is called a banded bonsai. Traditionally, this exercise is done with a band, but if you don't have one at home, that's okay. I'm going to show you how to do it without one. Keeping your elbows fastened at your hips and creating a fist with your hands, you're going to slowly bring those fists outwards. You should feel, again, a nice expansion in the front of the chest, and then your shoulder blade should be dropping downwards. This is really going to help to set your scap, and it's going to improve your posture. If you have a band, it's going to add that resistance to this exercise. You're going to do this exercise 10 times, and once you open your fist all the way, you're going to hold it for 2 to 3 seconds. Now we're going to talk about the lower extremity exercises. Again, we're going to start with a mobilizing exercise and then jump into a stabilizing exercise. The first mobilizing exercise is a hip flexor stretch. So go ahead and get down on one knee, making sure that you're maintaining a nice 90-degree angle at the knee that's in the front. What you're going to do is keeping your hands at your hips, you're going to contract your glutes and just slightly lean forward. This leaning forward should allow for you to feel a nice stretch in the front of that hip. You're going to hold this stretch for about 5 to 10 seconds, and you're going to repeat this 10 times. For For the last exercise, we're going to be doing a dead bug, which is a stabilizing exercise. So the first thing you're going to do is lie on your back. You're going to bring your knees and your hips to a 90-degree angle. There are a couple ways to do this. We're going to do the modified version first. So keeping your knees in the air, you're going to slowly bring your heels down to tap the floor. And then you're going to bring that knee back to meet the other knee. You're going to alternate legs, and you're going to do this until you hit the ground 10 times on each side. For the second modification of this exercise, instead of allowing the heels to hit the ground, you'll actually keep your knee locked out and let that leg slide all the way down to the ground. You're going to repeat this exercise 10 times on each leg. For the third modification, what you're going to do is alternate your legs and your arms. So as your right leg goes down, again, keeping the knee locked out, your left arm is going to go backwards. So you're going to keep your leg straight and your arm straight. You're going to bring both of the legs and the arms back to that neutral position, and then you're going to switch. Again, you're going to repeat this exercise until you've done 10 on each side. Thank you so much for watching. We hope that these exercises and stretches were useful for you.
Great. So those are, you can see they're, some of them are pretty advanced, some of them may be a little difficult, but there's something that you can do in your home and that can provide relief if you do have pain from arthritis. So if you are suspicious of arthritis and you go talk to your provider and they make the diagnosis of arthritis, what are things that we generally will do to kind of help combat it? The first thing, and really the best thing that we have to offer, is physical therapy. They'll be able to do exercises, strengthening, and really kind of teach you methods to maintain that joint stability. So one of the best things that we can do is really strengthen all of the structures around that joint, the muscles, the tendons, and that's done through exercise. That alone can really make sure that joint stays as sturdy as possible. So physical therapy is one of the first things that we'll recommend. You can try medications. The medications we generally will opt for are medications that will help with inflammation, those being Tylenol or ibuprofen or NSAIDs or non-steroidal anti-inflammatory medications. If you need to start some of these medications for arthritis, generally this is going to be a long haul. Arthritis doesn't go away in a week or two. It's usually a disease that can go for much longer. And so if you're starting these medications for discomfort related to arthritis, I recommend that you talk to your provider about what medications you should start, especially the NSAIDs, the non-steroidal anti-inflammatories, things like ibuprofen, Celebrex. Those can have adverse effects, and your physician or your provider may be able to guide you to which one would be best for you on an individual basis. There are other medications that we can use for pain, but we usually like to avoid these until last-ditch efforts, those being opioids and other pain modalities. The next thing that we can do is something called a knee injection, which are become very popular recently. These are generally done by physiatry, sports medicine, primary care does them, or orthopedists are the big kind of people that do injections. And what they would do is they would inject a needle into the joint space and inject either things that can kind of help buffer that joint space, whether it's fluids, or they can inject a medication like a steroid, which would decrease the inflammation, kind of calm everything down, which would help with pain. What we really opt for at the last stitch effort, this is when all other modalities have kind of not helped, and we've really gone through our list and someone is still feeling significant discomfort or having a difficulty with mobilizing, whether it's walking or doing the things that they used to love doing, then we'll talk about surgery. And that would be done under the guidance of an orthopedic surgeon. But talk to your doctor. All of these, there's a number of things that we can do. And really you need to have a treatment that is perfect for you. And that should be done on an individual basis again. So now I'd like to shift gears and talk about osteoporosis again. So osteoporosis was that bone disease, which you have more porous and weak bones. Unfortunately, or fortunately, this is usually a silent disease, and there are often no signs of osteoporosis prior to developing the disease. Sometimes you can have loss of vertebral height and you'll start to get this kyphotic spine, which you'll see in the picture on the right. This is one of the few kind of signs that someone has developed osteoporosis, but generally there's no clinical signs. You won't feel pain, you won't feel discomfort. And what makes the first diagnosis, unfortunately, all too often is a fracture, a new fracture. So screening for osteoporosis, it's important for me to kind of help or to tell you guys that the recommendations between our national society guidelines are not consistent. There are a number that are pretty consistent in recommendations for women, but it's not consistent for men and it's not consistent for transgender. So women who are over the age of 65 should all have a DEXA scan, which is a bone density scan, and I'll talk a little bit about that. Women who are over the age of 50 to 64 with certain risk factors should talk to their primary care doctor about it. And then men with risk factors should talk to their primary care doctor about receiving a DEXA scan. And anyone who is on hormonal therapy, whether that's androgen therapy or estrogen therapy, whether it's for trans health or gender affirming care, or if it's for things like prostate cancer, all of those people should undergo bone density scanning, or at least talk to their physician about undergoing bone density scans. So some of those risk factors that can lead to osteoporosis is diets low in calcium and vitamin D. In our American diet, we generally don't have too many people that are low in calcium and vitamin D. We could readily get this from things like milks and tofu and cheeses and high calcium rich vegetables. There are a number of people with bowel disease or history of part of their stomach removed who may have a problem with absorbing calcium. Or there might be people who eat a very strict vegan or vegetarian diet who might be low on calcium. So ensuring that you get adequate calcium and vitamin D. Also, we live in Philadelphia and we've got sun maybe 60% of the year, probably less. And so we are also prone to vitamin D deficiency because we know that sun is really important for vitamin D. Some medications can increase our risk of osteoporosis. The big culprit is steroids, and this isn't androgen steroids. This is steroids like prednisone or cortisone, fludrocortisone, and those medications can increase your risk of long-term use of those medications can increase your risk of osteoporosis. If you get a prednisone pack or a Medrol dose pack for 5 days, that won't increase your risk. But if you're on prednisone for years, that will increase your risk. Certain anticonvulsants can increase your risk of osteoporosis. And then antacids have an association with impaired stomach ability to absorb that calcium that's necessary for bone health. Some inactive lifestyle or people with extended bed rest can have a risk of osteoporosis. Another, tobacco use will increase our risk. Excessive alcohol intake or over about 10 drinks a week can increase your risk. Hormonal changes. So men, as you lose testosterone as you age, and women, as we lose estrogen as we age, can increase our risk. Age, which, as we age, I kind of mentioned that graph earlier where we reach our peak bone density mass at kind of 20 to 30 years of life, and then we drop off slowly. So we know age is really important in development of osteoporosis. And thin body size, people who are just a smaller structure, we've noticed for some reason we don't kind of fully understand, have a higher risk of developing weaker bones. Ethnicity, like I mentioned, Caucasians and Asian Americans, Pacific Islanders have higher risk of developing osteoporosis, and then family history. So what is a DEXA scan? DEXA scan is the way that we not only screen, but make a diagnosis of osteoporosis. A DEXA scan is an outpatient image. So you would walk into an imaging clinic. This would be prescribed to you by a primary care provider. And you go in and you have an x-ray done. They usually take an x-ray of 3 points of the body, sometimes the wrist, sometimes the spine, and sometimes the hip. What you do is you lay down flat on a bed and you have your legs raised up for those who can raise your legs. And they take a few x-rays. This is a very low radiation, very low time to be done, about 10 to 20 minutes. And there's absolutely no preparation that's needed before. So you don't need to fast. You don't need to, drink any kind of a contrast. And it's safe with metals. So you don't have to worry if you've had any kind of joint replacements or nails or any kind of prosthetics that have been implanted. What this bone density scan will do is it then calculates kind of how thick your bone is, and it compares it to someone of an equal age. It develops something called a T-score, which if it's less than negative 2.5, you would be diagnosed, or someone would be diagnosed with osteoporosis. If it's -1 to negative 2.5, kind of in right above that negative 2.5, those people would be considered to have osteopenia, which is a precursor to osteoporosis. So how do we prevent osteoporosis? Exercising. Having that increased force on a bone will actually increase its density. Getting rid of the tobacco, avoiding the tobacco not only helps osteoarthritis, but it also can help osteoporosis. Diets that are rich in calcium and vitamin D, and then avoiding alcohol. So some trans considerations, as I mentioned earlier, there's not really a uniform recommendation for trans individuals on bone density scanning, but UCSF, sorry, is a really great advocate for trans health, and they have recommendations which a lot of practitioners will follow, that anyone, regardless of age, should receive bone density scans at 65. Those who are between 50 and 64 with those risk factors that we kind of mentioned should undergo bone density scanning or considered. And then any trans individual that has undergone gonadectomy with suboptimal hormone therapies should undergo bone density scans. Some HIV considerations. HIV alone as a disease state will increase the risk of osteoporosis. And some of the medications that we use to treat HIV will also increase our risk of osteoporosis. Also, we have HIV infected individuals who are living much longer. And so HIV individuals have a higher risk of developing osteoporosis. And staying healthy with HIV includes taking the steps to prevent osteoporosis. So that is another important one to consider. So I mentioned maintaining a healthy diet and calcium and vitamin D. We recommend that an individual receive about 1,200 milligrams a day of calcium. And this is a really nice food chart just to kind of show where we can receive our high calcium foods, not just as it's seen in milk and cheese, but we can get it from soy milk, we can get it from yogurt, we can get it from tofu, we can get it from things like salmon and sardines. And so those who have modified diets can still get a great amount of calcium. And then also vitamin D, we recommend you get about 800 to 1,000 units a day for bone health alone. We also see that there's benefits of vitamin D supplementation and things like inflammation and prevention of falls. And so I recommend that anyone who can take vitamin D should take vitamin D. Again, if you have any questions about whether or not you should should or should not take vitamin D, I recommend you talk to your primary care provider. And then for those individuals who do develop weaker bones, how do we treat osteoporosis or osteopenia? We recommend continuing exercise. Don't avoid activity just due to fear out of a bone fracture, because we know that exercise can really put that strength or put that force on the bone to strengthen it. And keeping active kind of helps with a number of things. And so active bodies are healthy bodies. So keep yourself going. Nutrition, high calcium and high vitamin D. And then those who have osteoporosis could potentially qualify for medications that would increase your bone density mass. Those medications we commonly use that you may have heard of are bisphosphonates. These come with their risks and they come with their benefits. And so before this should have an extensive discussion between you and your physician about whether or not you would benefit from starting a bisphosphonate. There are a number of other medications that we have to offer to kind of help strengthen that bone, but this is one of the more common medications that we use. So for exercise, we recommend that you do strength exercising over 2 times a week. And you can see this woman right here is, doing her shoulder exercises, strengthening that back, strengthening her pectoral muscles, and that can go a long way. So some resources for you all for more information on osteoarthritis and osteoporosis. The CDC has some great information. Again, the UCSF also has a lot of great information, and then aidsinfo.nih.org. The Arthritis Foundation and the National Osteoporosis Foundation also is a great link. And then look at these little bony guys. I love them. Does anyone have any questions?
Thank you so much for that, Liz. There were a couple questions that came in, so I'll start with those, but also encourage anyone else to get your questions in now. So the first came in back when you were talking about fractures, and specifically about how fractures heal. And I would expand on that a bit to sort of what other medical conditions are going to impact how fractures heal, or how age is going to impact kind of that healing process. So anything more you can say on fractures and healing those fractures?
Yeah, so fractures can take time to heal. Some fractures need to be surgically intervened on to really make sure that they're a stable joint, to make sure that bone doesn't kind of slip out of position. Sometimes they don't need surgery to make sure that they don't slip out of position, and you can go for a time healing. Some people heal at different rates. As far as I'm aware, I don't know if Dr. Salzman knows, but there isn't really a difference in age in terms of how fast a bone will heal. As long as you're eating enough calcium and vitamin D and you have all of the elements to kind of have healthy bones, you should be able to strengthen as quickly as possible. It can be weeks, it can be months. There are some studies that look at using those medications for osteoporosis and our ability to heal a fracture. But that should be, again, a discussion with you and your provider. Hopefully that answered it, but it can be weeks to months to kind of heal a fracture.
Great, thanks. When you were talking about, I think it was when you were talking about arthritis and mentioned injections, both injections and surgery. Would those injections be, get an injection and you're set for a while? Are these regular injections? And also similar with surgical interventions, would that generally fix the problem longer term, or is that more of a temporary recurring procedure?
That's a great question. So injections are generally a procedure that you would need to have reoccurring. The hope is that you would receive an injection and you'd experience the benefits of that injection for several months. Usually we say 4+ months, but it can vary person to person. And we try to do those injections for as long as possible if they're beneficial to people. And there might be a discussion between whoever's doing the injections and that individual on how long they should continue them for. But we generally will reoccur them. They're a reoccurring procedure. And then surgery, it doesn't always lead to complete resolution of pain. So it is treatment that we have, and for many individuals that can help them mobilize, that can help them be active, that can help them with pain, but that's not 100% of the cases. So there are a number of people who will experience pain and difficulty with ambulation afterwards. And so again, that's one of the reasons we kind of try to leave it as one of our last options.
And then someone was asking specifically about, I assume this is a medication, Prolia.
Mm-hmm.
I don't know if I'm saying that right. But what are your thoughts on Prolia for osteoporosis? They also mentioned fibromyalgia.
So I'm not as familiar with Prolia and fibromyalgia, but Prolia is one of those bisphosphonates, and it's a medication that we like to use. I recommend it for the right individual, and it's got great outcome data. And so that's one of the ones that we'll go to initially. So I think highly of it.
And the Prolia is, interestingly, that's one of the newer monoclonal antibody medications. That's
I apologize.
No, that's okay.
Rank ligand,
it's denosumab, which is interesting. So we, just as Dr. Spina was saying, we tend to use a medication class called bisphosphonates as the first line because they have the most evidence to help build bone density and to help reduce fractures. So those are things like Fosamax, alendronate, Boniva. Those tend to be the first line. And Prolia is certainly an option for people who have really more severe osteoporosis or may have failed a bisphosphonate. And the other setting where it tends to be useful if people have kidney problems and they can't, and it's not safe for them to be on a medication called a bisphosphonate, then often rheumatologists will prescribe Prolia. Usually when you're taking Prolia, I would say it tends to be when you're working with a specialist at that point, just for monitoring that. Yeah.
Thanks, Dr. Salzman.
Another question just came in. So this individual said that they were recently told that they have arthritis, but weren't sure which type. And so is there a way to tell which type of arthritis a person has?
I would ask their physician. Usually if that diagnosis was made just based on history and an x-ray, my suspicion would be that it's most likely osteoarthritis. But I am not fully aware of what they what had talked about with their physician. There are some characteristics on the way that the arthritis presents, if it's worse in the morning versus how it progresses through the day, that can kind of lead us to believe if it's one type of arthritis or the other. But I would say the best way to find out is ask your provider, whoever diagnosed you with arthritis.
Okay, so that's something that the provider would pretty easily be able to distinguish when they were making that diagnosis.
Yes.
Any other questions? Encourage folks to get those into the Q&A or into the chat. I will check Facebook again to make sure we get that. One other one, Liz, when you were talking about physical therapy, is that something that typically, I always like to ask sort of what's someone going to a geriatrician for, or for their primary care, or physical therapy in this case, so is that something, if someone brought that up with their doctor, they would get a referral to a physical therapist? Would someone be seeking out a physical therapist on their own because they sort of know that they have this pain? So how do you work that on your end in the medical system of what's going to get someone to a specialist, a physical therapist in this case?
There are actually a number of providers who would be able to refer you to a physical therapist. This could be orthopedics, this could be your primary care doctor, this could be physiatry. And so it's not necessarily exclusive to primary care physicians that would be able to provide someone with a script to go see physical therapy. However, a lot of times for convenience sake and for accessibility, most people will go to their primary care doctors to have to kind of talk about physical therapy and get that prescription. Physical therapy can be given in a number of settings, and so it can be out at an outpatient physical therapy office where you would go and they would have a gym, but there's also the availability of home physical therapy where a physical therapist would come to the home and work with you in your own space. But this can be prescribed by a number of different providers.
Just got another one come in. Let's see. So just to quote this person's question, I had an ankle fracture, in December. It was inside of the left ankle below the bone sticking out, and was told that it would take long to heal. It's not swelling anymore. It's not swelling anymore or any pain, but other parts of the ankle may feel weak. So it sounds like after the fracture, that place has mostly healed, but now getting pain in other parts of the ankle or other swelling or weakness.
Yeah, and that's something that we see, unfortunately, with fractures is all of the sequelae that come with a fracture. It's not just a simple bone healing. There's so many other complications that you can experience from it. And so my recommendation for that person would be to consider working with physical therapy. They can help kind of work in other areas to help with mobility, to help with the swelling, and continue to move and talk, be transparent with your primary care provider. But unfortunately, that is something that we will see commonly, people who have fractures who develop pain or discomfort in other areas after. So I sympathize with that person.
And just, it's a good thing that the bone is healed, like the fracture is healed, which is the first step. And just as Dr. Spino was saying, when you have that injury, many other structures, muscles and tendons, may have been damaged in the process. So physical therapy can really help with the recovery after the bone heals.
Excellent. Thank you so much. And thank you folks for these were all good questions. I think we can wrap it up there then. And so thank you so much to Dr. Spina for sharing this information with us this afternoon, Dr. Salzman for joining us here. We'll do a quick plug that our next Doctors In program will be on Tuesday, June 8th. We'll be talking about dementia and cognitive health. So we hope that you will come back and join us for that one.